Welcome again, everyone, to tonight's webinar, 2025 CDT code changes, the key updates and how to adapt. I'm Shirley. I'm going to be your moderator this evening, and I am so thrilled to introduce our speaker again, Dr. Greg Grobmyer, who's been with us before. He is a former clinical dentist with over a decade of experience and now leverages his expertise in practice systems, marketing, and communication to help dentists nationwide as the senior advisor and editor-in-chief of Practice Booster. Before we dive in, let's quickly go over some housekeeping notes. You guys are going to have questions, so if you have any during the webinar, please go ahead and type them into the Q&A box at the bottom of your screens, and go ahead and enter them as they're coming up for you. We will address them. Dr. Grobmyer will address them at the end of the webinar. And also please note that CE credit is not available for this webinar. And lastly, if you've registered for tonight's webinar, you are going to get a link to the presentation that we will be sending out via email sometime in the coming week. Okay, with that, Dr. Grobmyer, thank you so much for being with us. I'm going to pass it over to you now. We're really excited to hear you
It
speak.
is always a pleasure to be here. This is to me, for a kind of a code geek guy, this is Christmas. This is the time of year when all these new things are popping out, and we really get to shine. We get to kind of show off what the CDT has done over this last year and what we expect for this upcoming year. I already saw a question about, will there be a download we can print out? I do have a QR code that's going to be at the tail end of this thing where you'll be able to download the CDT code changes for this year and the last 2 years. And so stick around and you will be able to get that and access to that. So that was answer a question before we even get started. So again, before we get too far into it, I do want to thank my sponsor for tonight, which is eAssist. eAssist invented the optimized revenue cycle management and front office services for dentists. They were really one of the first, if not the first, dental billing companies. Their CEO, Dr. James Anderson, who's a good friend of mine, he kind of saw a need. He started doing this for some of his own practices, realized that it was probably something that a lot of other dental offices needed as well, and began to create these systems for dental billing. And then that's expanded. So for over 10 years, they've been doing this for dental offices, and over 3,000 dental offices and DSOs are now served by eAssist, and they've collected more than 19 billion. That's billion with a B. That's a big number. $19 billion from insurance companies on behalf of dental practices. And so very highly awarded, great company that we are proud to work with. eAssist is not just dental billing, however. That's what probably first pops to mind. That was their core competency. Their primary thing that they began doing was dental insurance billing and aging. But they've added so many other little a la carte things. You can pick and choose. You don't have to do it all, but they do offer all these other services: patient portion statements, billings, collections, insurance verification, credentialing, eligibility, accounting, bookkeeping. They do have CPAs. They are official CPAs that are with the team, reconciliations and EFTs, and then a relationship with Full Schedule, which is actually spun off to be its own thing now. Full Schedule, patient recall and retention. It's keeping your schedule full. They're great at reactivation, and that is now its own standalone company. So that is eAssist. Then this is me. This is me. I'm Dr. Greg Grobmyer. I am the senior advisor and editor-in-chief at Practice Booster. I was a clinically practicing dentist in Tennessee for over a decade. I went through a cancer battle when I was 36 years old. And so ended up going to the doctor, talking about acid reflux, and found out I had needed to get half my guts taken out. That was kind of a bad day at the office, to say the least. But same day I went in for treatment, I had surgery and followed that up with chemotherapy. The chemo has left me with peripheral neuropathy. I had numb fingers, numb feet. And when I got to where I couldn't button buttons on my shirt, I'm like, I don't need to be handling a handpiece anymore. Stepped out of the clinical side of things and over the course of the decade that I was in practice, I was a client of practice management coaching and consulting. And so stepped over doing that for a long time with practices across the United States. Wrote a lot during this time. I was kind of promoting myself also as the writing dentist. And that led me eventually to work with Dr. Charles Blair, the eminent Dr. Charles Blair. He was kind of the GOAT of dental insurance. He's the original creator of the Dental Coding with Confidence manual, which I hope you have within your office sitting on your front desk. If you don't, you should. And so it takes everything that's in CDT and expands upon it about not only just what the codes are, but how to use them and what the expectations are from insurance and what the documentation should be and what the narrative should be, what images go with it, all that good stuff. And so I got to be mentored up by Dr. Blair. I worked with him for the last 5 years. We did lose Dr. Blair a little over a year ago. He's no longer with us. He did pass, but I'm getting to step into those big shoes and ride those coattails, do the things that he's done before, and take over his one-on-one consulting, as well as writing the Coding with Confidence book and the Insurance Solutions newsletter, among other things. And so if you want to read any more about me, you're welcome to pause and read the slide, but we're going to move along. Disclaimer before we get going. This basically just says everything is current as of today. Things change all the time. CDT codes change. They do mid-year updates. Laws change, rules change. Our ideas or concepts of things may alter as well. And so as of today, we believe these things to be factual and true. So, but you are responsible for verifying that for yourself. All these things are advice given based upon our clinical expertise, but we are not attorneys, and this is not legal advice. If you do need legal advice, please seek out a healthcare attorney within your state. So with that, the objectives for today, we're going to want to kind of understand why we change the codes, how they're changed, what goes into the process. We want to make sure that we're understanding how to integrate these codes into our practice management software and in use, what we're going to expect from the payers and things like that, and just how to effectively stay compliant with the latest coding regulations. And that's going to cut down on those denials and those potential audits. The longer you have before a claim is paid, that's costing you money. And so we're wanting to make sure that we're getting clean claims on the front end, and we're collecting everything that we can legally collect for you, maximizing your reimbursement. And so as a matter of fact, that's a conversation back to eAssist. We've got 2/3 of people, we're talking 70% of dentists, according to NADP, that's the National Association of Dental Plans, 91% is the national average collection ratio. So that means that 9% of collectible revenue, we're not talking about things that are uncollectible, collectible revenue is just not collected by dentists. And so that's a huge amount. If you're really thinking about it, if you've got a practice that's 60% overhead, 40% profit margin, and you're leaving 10% almost on the table, well, that 40% profit margin, you're only getting what, 30%? This is actually a 25% increase if you could pick up that last 10% of collectible money. This is money that's owed to you, but is just not getting collected from either the insurer or from the patient. There's a good chance that a lot of this may be done or may happen due to claims that aren't clean, that there's something wrong with the submission that they're doing to insurance. It could be deleted codes, outdated things. You're not aware of certain coding that you could be doing. That's a huge thing. And so we're wanting to make sure through all this process that these unnecessary claim denials are wiped out. We're wanting to make sure, look at these figures. If you're talking about a $1 million a year practice, okay, I would say that's probably even a little low looking at the practices that I work with. But again, this is from 2023 ADA's Health Policy Institute survey of dental practices. And so average dental practice was $936,000 per provider. And so if you look at 9% of that, that's over 40 years of practice. That's over $3 million of money that's not collected. That's huge. So we want to make sure that this is getting we're getting accurate claim submissions. We're wanting to make sure that we've got the right CDT codes on there, that we've got the right documentation, the right attachments. Those are the things that cause delays. Those are the things that cause denials and issues with timely filing. We're wanting to make sure that that's stuff that's preventable. It's things that shouldn't be happening. And so we're wanting to make sure you have updated coding resources, and we're going to try to help you minimize your risk of having those claims denied unnecessarily. So, did you know even patients, yes, even dentists who don't participate with dental plans, we're talking about people that are fee for service or out of network, if you are submitting to insurance in any way, shape, or form, you are subject to audit. You don't have to be in contract. You can be audited. And so a lot of people who are fee for service don't think they have to worry about audits, but reporting the codes are same whether you're in network or out of network. This is set up through federal laws as being the correct language of dentistry, CDT. And so you have to be using the codes, and you have to be using them correctly through any electronic submissions or any electronic transference of data between payers and offices or between individuals. This has to be done. And so no practice is immune to insurance audit if they have any insurance involvement whatsoever, even out of network. So these audits are performed on a regular basis by payers to guarantee that not only contractual obligations are being met, but also state and federal government mandates are being upheld as well. So the focus of these audits is to verify that the treatment billed was necessary, that it met the standard of care, and that it was reported accurately. And so if there's any misreporting or things that are going on that seem shady, that can still come back and get you, even if you're not in network. Now, very few providers are just randomly chosen for these audits. Most of the time, this is based upon billing habits of the provider. And so there are certain audit flags, and I talk a lot about that in my consulting, certain ratios of particular codes that catch their eye and make them wonder whether something kind of is going on that shouldn't be going on. So now this is my mentor. This is my man, Dr. Charles Blair. Correct coding often results in higher revenue as practices obtain reimbursements that were once unpaid because of misunderstanding or misreported codes. The golden rule of dentistry, and this is straight out of ADA's book, is to always code for what you do. And so that's the number one thing. Report what it is you do. Doesn't mean it's always covered. Doesn't mean it's always a covered service, but you should report what you do. It needs to be accurate both in the clinical chart and in the submissions on the claim form. If you're changing it up in order to gain different reimbursement, that can get you in a lot of trouble. That's kind of lying on the claim form, which is a federal form, which is not good. So without these up-to-date coding resources, you have no idea whether you're reporting what's accurate or not. You don't know a lot of times that you're not doing something correctly. I work with practices one-on-one quite frequently with what we call our revenue enhancement program. So several times a week, I'm doing these 3-hour consults where I'm going over the coding practices of a particular practice and walking them down through coaching, hey, you're using this code correctly. You're not using this one. Maybe you didn't know about it. Documentation, what images, what narratives need to go with it and things like that. And so, but I invariably find deleted codes being used, codes that could be being submitted, being not being submitted, or you turning in some codes thinking it means one thing when it actually means something else. And so you can't just go by the little nomenclature, the top sentence or line that's in your practice management software. You really have to have an understanding of the codes and what they mean. So we are going to be talking about those descriptors tonight and those changes to those descriptors. So this correct coding is going to result in higher revenue because you're going to get your reimbursements back in a timely manner. You're going to get ones that weren't being paid, they were being denied. But now if you're doing it correctly and submitting with the right documentation, those are going to get reimbursed. 200 code changes in the last 5 years. So if you're not keeping up with these ADA code changes, you are way behind the mark. You don't know what's happening. So over 200 code changes within the 5 years. For this particular year, we've got 24 that we're going over tonight. In fact, we're going over not only what the code changes are, but why they happen, how they happen. Codes are changed because dentistry changes. There was a time where we didn't have composite resins. And so there wasn't a code for that. When this new technology comes along, new codes are created for the new procedures, the new technology that comes out. Sometimes old procedures are put to pasture. Those old codes are removed from the code set. Sometimes they're absorbed into another code. You need to know how that's going to be remapped. So code you may be using within your practice all of a sudden doesn't mean the same thing it used to, or it now is not an active code anymore. It's been absorbed into a different code. So if you want to ensure that timely filing and reimbursement's happening, you got to stay up to date on these code changes. And then how these codes change. Every year, there are submissions to what we call the Code Maintenance Committee. I get to go up there every March to the Code Maintenance Committee meeting. It happens at ADA's headquarters in Chicago. So in March, we go up and we listen to all the different proposals for changes that have been submitted. And who submits them? Anybody. You can submit a code change if you want to. If you feel like there is a procedure or a thing that you don't have a good way of documenting and you feel like it deserves its own code, you can go to ADA's website, search for Code Maintenance Committee. You'll find a link there for a form that you can fill out, you turn in. If you turn it in by November, those code changes proposals will be discussed the following March and voted yes, no, or let's tweak it a little bit. And then those are incorporated into the following year's CDT. So code changes are happening every single year now. So these are the code changes for these years. We want to make sure that in the last, there's been so many recently. And so we want to make sure that you're keeping up with all these. Again, this year, we're looking at 10 new codes. We've got 2 that are deleted. Those need to be removed or inactivated in your practice management software. I don't like to delete them entirely because you need to be able to have the history of that and see, when you've done it before, your reports will pull up funny if you're looking at something old. But you do want to mark them somehow. Note it in the chart very blatantly that these deleted codes need to be not used. We've got some different code for that. So new codes, deleted codes, that's pretty obvious what they are. We see revised codes, and we also have editorial revisions. Those are 2 different types of revisions. The revised codes are what we call substantive revisions. That means they changed it or tweaked it in some way that actually changes the meaning or the scope of the code. And so that's a substantial change. That's a change that you really need to pay attention to, because the meaning of the code has been revised. The editorial revisions, I'm not even covering those tonight. They moved a word from the ending to the beginning of the code, or they changed the punctuation, or something that did not change the meaning or the scope of the code. It just may be grammatical, something like that. And so editorial revisions, essentially, I'm not so concerned with, but the revisions, absolutely. Mid-year updates, there were none for this year. There have been in the past, particularly during pandemic. They had a lot of mid-year, push for COVID vaccine codes and things like that. So that needed to get out in a timely manner. They didn't want to wait till the following year for those to go into effect. So they did some mid-year updates. We do not have that for this year. There were also changes, as we know, to the claim form last year. And so we've now had a full year with the 2024 ADA dental claim form. So a lot of you are probably still not using it. It's not been fully integrated into every practice management software across the board, but most of them have. They're beginning to use this. It took a little while to get everything mapped correctly, so that when you put things in the box, it automatically filled in the correct forms and things on the end of the claims processing centers and departments. And so the nice thing about the changes that happened to ADA dental claim form in 2024 is they were all additive. No box changed numbers. They didn't shift something entirely. Everything that was already there is still there, and it didn't change. And so it's the same as the 2019 plus some. They added a 3A for payer ID, which was, so 3 is still the payer address and things, but the ID is now carved off into its own little box. 11B now exists. Now that's for other payer ID. There's a 39A for the date of last scaling and route planning. We can all see how that would be beneficial to know, right? And so they're carving that little piece of information out to where it's easy to find. It can be scanned by computers. These payers are using AI now. They're using they've always used computers to scan these forms and look for certain things. It's getting more and more prevalent, not only on the looking at the forms, but also reading radiographs and other things, looking for keywords and narratives and that kind of thing. And so, but having that carved out into one spot where it's repeatable makes it a lot easier for the adjudication of claims. And that means things go faster. Okay. Things move faster. And then there was some stuff about locum tenens. And so if you haven't incorporated the 2024 claim form, do so as soon as you can. You really should be using this one by now. It would be ideal. If you're still stuck on 2019 for whatever reason, your practice management software won't let you or whatever, it's okay. You're not going to get in trouble. Okay. But as soon as possible, please do shift. You really should be, in theory, using this one by now. So with all that said, now we're going to get into the actual code changes. I know this is what you're here for. This is the meat. So we're going to dive right off into this. I want you, as a lot of you that are on this call are practice management or practice managers, your office managers. You may be the insurance person for your office. Your administrative in nature, but these changes kind of need to go out to the whole team. There's a lot of things here that also apply to the clinical side of things because a lot of it has to deal with documentation. Okay. Whenever I'm doing my one-on-one consulting, I'm discussing the documentation that needs to happen from the clinical team because things need to be correct in the clinical chart in order to carry over to any narrative or any other submission. A lot of times they're wanting to actually see the notes from the date of service now as the narrative or instead of a narrative. And so those are the things that are needing to be an attachment, which means it's up to the clinical people to make sure that all the correct keywords are there that AI is looking for, that all the correct verbiage is there, that all the correct images are taken, photos are taken, radiographs are taken. We're wanting to make sure that all that's done. There are also changes not from the diagnostic side of things as far as whether a patient needs a certain service or not, but as far as the changes with the payers and what their clinical criteria are. For instance, this last year, we saw a huge change with 4341, 4342. They're asking for a lot of different things now that they didn't used to ask. The codes haven't changed. The diagnosis, the whole staging and grading has not altered, but what criteria must be met for claim submission has changed. And so that has evolved. They're asking for things like start times and stop times for perio. Okay. They're asking for types and amounts of anesthetic given. They're more focused on radiographically observable bone loss than they are about pocket depths. Okay. Those things have kind of altered. They're using AI to look at your bite wings and make sure that enough bone loss is evident in order to adjudicate that claim. And so first you may be thinking, oh, insurance is just trying to make this more difficult for me. And maybe, but really it's in direct response to clinicians submitting claims that were arguably kind of shady. There was a huge number of people submitting 2 quadrants of perio, full quadrants, in 30 minutes of time. And that's either something's not going on right there. That's not going to be probably clinically quality delivery of care. Okay. And so insurance is hesitant to pay for those types of things. And so also just because a patient meets the clinical criteria for having a disease process, it doesn't mean they meet the claims criteria for reimbursement that's outlined in those plan documents. Okay. Those are two separate things. They can have perio without having perio bad enough for the claims to pay. That's outlined by the payer. That's somebody in a smoky boardroom who is deciding when they're going to pay a claim or not. What are the criteria? It's not just that they have the problem or that they need the treatment. There's other claims criteria that must be met. And so that is decided by that patient's employer, perhaps, or maybe by the insurance company themselves, depending on who has created, if it's self-funded or fully insured plans. So there's a lot. I'm kind of going off in the weeds a little bit. We're not going to be deep diving into the payer criteria changes, but we do teach it in a lot of our other courses in our revenue enhancement consulting. So, all right. First code change that we're going to be talking about tonight. This is D0160. 160 is the detailed and extensive oral evaluation problem focus. So this happens after you've already had a comprehensive exam. You've already had a 150 or a 180. If you're not using 180, please learn about D0180 and when it's appropriate to use that. That's a great opportunity for your practice. Let's just say that. I've got a full out podcast on that one. So the D0160 can be used if you've diagnosed a particular problem that the patient has, and then that particular diagnosis needs its own treatment planning and more extensive evaluation. So they listed a few different examples of conditions that could require this, including things like dentofacial anomalies, complicated perioprosthetic conditions, TMJ dysfunction, facial pain, and they've added in sleep-related breathing disorders this year. And so that was the change that happened. They wanted to put that in to specify that that is one of the things that D0160 could be used for. Now, this is not a comprehensive list. There are other things that could fall under D0160. It's not limited to just the things that are listed there, but this could be a code that you are using in your general office. It's not specific to specialists or things like that. So be aware of this code and the changes that have happened. D0801. Okay, D0801 is the scanner code. Okay, now the vast majority of the time, if you're taking a scan in order to create a prosthesis, that's just like taking an impression. You'd be taking an alginate, you'd be taking a PVS. You're not going to be necessarily reporting that separately, particularly with a fee on it. However, a lot of dental practices are using this as a wellness scan. They're doing this as a part of patient records. And if that's the case, that is diagnostic in nature. And so we're taking an image now. We've got that we can compare it to a year or two down the road. We can do the digital subtraction. There's a code for that. See how changes, has a jaw grown, has a tooth moved, has a lesion gotten bigger. We've got that full mouth scan. They made the change this year. It had previously said dental surface scan direct, and they changed that to be intraoral. They wanted to make sure that it did not imply that it was only teeth that this was appropriate for. It is also for any intraoral structure. And so any aspect of the intraoral anatomy, that's new language that they added on also. And so be aware of that. And D0801 may be something that you want to start doing within your practice. If you want to start adding that to your new patient exam, right now it's not a covered benefit by insurers, but the more and more people use this, the more likely it is to become a covered benefit. So they want to make sure that that's an appropriate code for you guys to use in that case, a baseline scan for patient records. Next change, oral hygiene instruction. This is one that many of you are already putting in your records. Don't have to, but having D1330, Alexa's helping me out here. Having D1330 oral hygiene instruction as something that you're noting during your recare visits is a great way. You don't even have to have a fee on it. You can do this as a walkout with a no fee. It's a value add for the patient. Hey, Dr. Smith, did this extra service on me and didn't even charge me. But it's a way to document that it happened. It's a way to note in the clinical chart and in the electronic record that oral hygiene instructions occurred. And so the reason they revised it is because they were giving examples. They were saying stuff about home care and some very specific examples of what it could be. They thought that was limiting. Oral hygiene instruction could be a huge number of things. I mean, more things that could be listed than just in that one little block of text. So they didn't want to limit it. They want the provider to decide what they consider oral hygiene instructions. Now, it's really good when oral hygiene instructions are delivered to note what it was in the patient record that you talked to the patient about. If they're needing to focus on using a water pick per your instruction, note that in the clinical record. So next time you can talk about them, follow up, see if it's something that they're doing. And so, but oral hygiene instructions are supposed to be personalized for each patient. They're not limited to just home care or just the examples that were in this description. And so that was the reason for this revision. Next one. Hey, this one's pretty cool. Placement of an interim direct restoration. Used to be protective restoration. Before that, it was sedative filling. So they've changed this one multiple times over the years. But this is to really emphasize the fact that it is an interim, meaning temporary. It's not there. It's not definitive. It's not the permanent thing. And that it is a direct restoration. It is not indirect. It is not fabricated out of the mouth and put in. This has to be direct placement. So that would be composite resin or IRM or whatever, temporary filling material that's there. It could be flowable. It could be anything that you're putting in there that you're not intending to be there once the definitive restoration is in place. And so, but they did change the verbiage a little bit, not only to that nomenclature. The nomenclature is that first sentence, placement of interim direct restoration. They also changed the descriptor. The descriptor is this paragraph. This is the thing that gets a lot of you guys in trouble because you're not looking at the descriptors on these codes. And so the descriptors outline certain criteria that have to be met sometimes, certain things that have to be documented in the clinical record in order to say that you delivered that code. And it kind of outlines what the code is and what the code is not. Sometimes it'll say can't be used with this other code or things like that. In this case, they added some verbiage into the descriptor that said it's to relieve pain, promote healing, manage caries, create a seal for endodontic isolation, or prevent further deterioration until definitive treatment can be rendered. Okay, so that's just kind of clarifying what an interim direct restoration is. That seal for endodontic isolation, that's building a wall. Sometimes you'll prep down, maybe it's a box and it goes a little sub G, and then you get some bleeding or some saliva. It's difficult to kind of keep that isolated and keep your canals dry. So you may build a little wall out of flowable. Okay, that's now placement of an interim direct restoration. So those things have been directly called out so that they must be included as a part of the D2940. So D2940 is kind of one of those codes that could be a take back code, just so you know. When you're turning this into insurance and you end up following it up with a definitive restoration shortly thereafter, sometimes they take back what they paid you on a D2940. They'll deduct it from the permanent restoration, the buildup or the filling that you might do. So just be aware of that as well. Now, when they created this code and did this revision, it absorbed another code, and that's the D2941. D2941 was deleted, and it was kind of this particular procedure was added into D2940. This carved out originally the way that it was that it was an interim therapeutic restoration on primary teeth. Most of the time, this was sitting a kid in your lap and maybe spooning out some decay, possibly putting some IRM or some type of temporary material in there without fully treating the caries. And so it wasn't considered a definitive restoration, but it was caries debridement by hand or other method, and then kind of temporizing it until something else can be done. So they felt that this really kind of fell under the other code. And so they combined those. And so there's people happy about it. There's people not happy about it. Some of the ones that do public health really liked having this as its own particular code. The pediatric dentist selected it as its own code because now it falls under the same. It can't really be treated differently by a payer from the D2940 because it's now all the same code. So make sure you are inactivating these codes. I did mention that before. Make sure that they're not accidentally used. And go back to previous years. Look at the codes that are in your practice management software. Like I said all the time, I'm seeing D6052 for locators for implants. That code hadn't been used in 3 or 4 years. Separate codes for child prophy or child fluoride versus adult fluoride. Those codes are not active anymore. Okay, it's now either a varnish or anything but varnish. And so 1206 and 1208, but those other codes are now deleted. They've been taken out of the code set. So make sure they're inactivated. You're not accidentally submitting those codes because they will immediately come back with a denial. So 2941 is now one of those codes. If you submitted this today, it would immediately get denied. So also look out for when they're in explosion codes. Watching Teresa Duncan, my good friend, recently do her presentation on the code changes. She did talk about explosion codes and multi-codes. That's a great thought. I thought I'd include that one in mine too. Absolutely, they're buried sometimes in these explosion codes, and you got a deleted code. And if you're not removing it from that, you're still reporting it unintentionally. So don't forget about that. Here's a new one that's pretty interesting. 2956, removal of an indirect restoration on a natural tooth. This is cutting off a crown. There is now a code for being able to remove an old crown. And so now payers, I guarantee you, are going to consider this an integral part of a new crown preparation. So if you're taking it off to replace it with a new crown, more than likely the payer is going to be saying they're going to be treating it like they always have and not reimbursing that as a separate thing. But if you're fee for service, if you're out of network, absolutely. It takes 6 diamond burrs to cut off a certain type of crown, that's extremely hard. You ought to be able to charge for that. And so this is a fee that could be charged to the patient in this circumstance. You'll have to read your EOBs. You'll have to read your plan documents. By this time, the payers mostly have their new plan documents out there for you to look up these new codes and see how they're going to be treated. In network, the majority of them are going to say that it is included in the restoration and not to be charged separately to the patient. However, out of network, fee for service, absolutely charge for this if you feel like it's appropriate. And so this code is to be used and reported once for each crown that's being cut. And so if you've got a 3-unit bridge, you're going to code this once for each retainer crown, okay? Not for the ponic. So it's not for each unit of that bridge. It's the ones that are actually getting cut. And so that's the thing. Now, you may be thinking, hey, didn't we already have a section of bridge code? Yes, we did, but that's the 9120, D9120. But that one is specifically leaving one retainer crown in place. So you've got a bridge that perhaps the distal tooth is failing, it's rotting. You're sectioning the bridge to remove the ponic and the back retainer crown and root, but you're leaving the front retainer crown as the definitive prosthesis. That's a D9120. That's different from this. This is removal of the whole thing. And so if you're removing an entire bridge or just a single crown, absolutely you can use this code. Now note it says not to be used for temporary or provisional restorations. Can't cut a temp off and use this code. That's not appropriate. This is for the removal of a previously placed indirect restoration on a natural tooth. Okay, natural tooth, not an implant. Okay, it may be used for replacing a failing restoration or to determine the extent of decay and prognosis of the tooth prior to treatment planning. Those are reasons why. So reasons that they gave when the code maintenance committee met about this new code. So moving on, Notice I skipped over quite a bit. This was we went from restorative all the way to the implant section. There weren't changes in the endodontic section or the perio section this year. First time in a long time that we haven't seen changes in perio. So for 6011, now we're expecting a lot of changes not only this year but in years to come. Implants are a booming part of dentistry, and because of such, not only are the procedures changing and the way that we deliver implants is changing, it's becoming a much more common service. And so, because of that, the CDT coding is going to be expanding as well. So, there are several new codes within the implant section this year I wanted you aware of. The first revision was to 6011. This was surgical access to an implant body, second stage surgery. So, this is when you've placed an implant and for whatever reason the healing cap came off or the temporary abutment may not be there and the gums have grown, the gingival tissue has grown up over the top of the implant body and has to be removed before the new cap or whatever abutment is placed. And so the way that the code was written before, they felt was too wordy, it was too specific. It doesn't matter what kind of fixture is going back after the surgery. That was irrelevant. And so they took off all those examples because it really doesn't matter. Doesn't matter what's going back. It just matters that tissue is being removed from around the implant body in order that something else could go on top. So that's a separate procedure. It can be charged separately, although a lot of the payers consider it inclusive to the placement of the implant. So read your plans, see what they say, but this is a separate procedure that can be coded out as a separate event. Okay. 6080. There's some revisions here. This is implant maintenance procedure. Now, I see a lot of times online, I look at all these Facebook forums. There's some good information on Facebook forums, and there's some bad information on Facebook forums. Be cautious when you're getting advice on on an online forum like that. The 6080 implant maintenance procedure, this is specific to full arch fixed hybrid prostheses. Now, this is really what they always intended, but it's not the way that it was originally written. The way that it was originally written, they were just saying when a prostheses are removed and reinserted. And so the way that that was interpreted before, there were people that were taking single crowns off, cleaning them and putting them back and calling that implant maintenance. That's not the case. That's not a proper use of those codes. 6080 is specifically to a full arch fixed hybrid, also known as all on X. So all on 4, all on 6 type prosthesis. And it is when it is removed and reinserted, including the cleansing of the prosthesis and the abutments. And so they took off any kind of language that would lead you to believe anything else about it. So 6080, checking the whole thing off, you're looking at, you're inspecting it. You're also cleaning the abutments. If you notice that, you're cleaning the implants in the patient's mouth. That's included in this, okay? So all that is together, and then you are putting it all back together again. So if you're cleaning and reinserting implants or abutment supported crowns, bridges, partials, removing, cleansing, and putting them back, there's not really a code for that now. And so that would fall under a D6199, unspecified. Unspecified codes are in every single category of service. Most of them are 999 codes, but this one is a 6199. And that's because that's the end of the implant section. The implant category goes from 6,000 to 6,200. Okay. Or actually the new one starts at 6,200. So 6199. So not all of them end with a 999. This ends in a 6199 if it's unspecified. 6081, scaling and debridement of a single implant. So this is when you've got one hot tooth, one hot implant that is inflamed and has mucositis. That is the specific thing that they wanted to call out. The periodontists who sit on the code maintenance committee wanted to make sure that it's not just inflammation we're talking about, not just a little redness around the gum. They wanted to specify that this was inflammation that included bleeding upon probing and increased pocket depths. Okay, that's the definition of mucositis versus just a little bit of inflammation. And so this is more than just a little redness around the gums. Okay. So if you're needing to scale a one implant, then 6080 is the code for that. Now, note it is not performed on the same date of service with a prophy, perio maintenance, or a 4346, which is the gingivitis code. And so can't be on the same date of service. It has to be done on a different date. It is per implant. So you might have 2 or 3 of these that you're doing at the same time. That's okay. You report it 2 or 3 times. All right. And you should probably put a narrative with this. It doesn't say you have to, but we feel it's best to support the submission of this by describing the mucositis that's present. So provide those probing depths, provide those bleeding points, show those radiographs that show bone loss, photos, any of that's going to support 6081. It'll only be a covered benefit if there is an implant rider on that plan. And but if there is, it's usually covered. I think most of the ones I've seen are once every 24 months, but not in the initial year of placement or something like that. The language is going to vary from plan to plan. You can always code it. It's just not going to get paid except on the certain frequencies. Next, D6090. 6090 was the repair code for implants supported prosthesis. So this is any type of implant supported prosthesis. So it could be a all-on-4, it could be a single crown, okay, whatever. If you're needing to repair the porcelain on a single crown, that's going to fall under the 6090 code. Repair codes, much like the unspecified codes, they don't have a fixed fee. They don't usually have a fixed reimbursement because usually, frankly, they're not reimbursed, generally speaking. This is a thing that's going to be an out-of-pocket expense for the patient under most circumstances. There may be an allotment that's given towards it, but if you're looking at fee schedules, but for the most part, this is going to be something that varies because there can be simple repairs and there can be very complex repairs that happen to this. Now, they did combine the 6090 with this next code, 6095. 6095 was repairing an implant abutment. So the first one was for the prosthesis. This one was for the abutment. They felt it could all just go under one code. In fact, a repair to an abutment is a very rare thing. You didn't really see it too much. So they thought this was redundant and unnecessary. Now that we had the 6090 code, that's all repairs. So every implant repair is going to go under 6090. 6180. This is a new code for this year. So we talked about 6080 implant maintenance a while ago, where you took everything off, you clean it, you inspect it, you put it back together. Well, this is also implant maintenance for a full arch fixed hybrid prosthesis. So that's all on X. Okay. Still that. But this is when you don't take it out, when you leave it in place. In fact, the American College of Prosthodontics came out and said that they felt like the removal of a fixed screw-retained implant prosthesis for evaluation was not needed unless there were signs of peri-implantitis. If there were signs that there was an inability to clean it, if they had poor oral hygiene, so, or if there were any type of mechanical complications that required removal. But in other circumstances, they thought it was better to just leave it in place and clean it in place. And so D6180 is the new code for that procedure when you are not taking it out, but you're actually cleaning it, almost like doing a prophy to the natural dentition, but you're doing it to the all-on X that's within the patient's mouth. So there's 6080 and 6180 now. 6193. Thank the Lord we finally got this one. This is a code that's been needed for some time. This is replacement of an implant screw. So before it kind of fell either under a repair or maybe that unspecified code. There really wasn't a code for an implant screw. So, but there is now 6193. Now note, when you're doing a replacement of a screw, you're also more than likely going to be able to do the 6197. People forget about that one. That's the replacement of the restorative material to close the access hole. And so filling back over the screw hole is a D6197. So payment on that one varies, but that is a code that you can report. Usually set the fee similar to one surface posterior resin, something like that. There's some other codes that I have there that are interesting that you might want to note. The 6089 for accessing and retorquing. That's a fairly new one. And so you wouldn't be doing that. You wouldn't be replacing the screw there. 6089 is tightening up the screw that's already there. You could do a 6197 though after doing that. 6193 is the whole screw. Now, if it's broken, the screw is broken, there's a 6096 code. That's the broken screw. That you got the head of the screw is in the crown, but the body of it's still down on the implant. That's a difficult situation. And so you could also do the new screw and the filling that goes back in the hole. 7252. This is a new surgical code. There's two new surgical codes. 7252 is a partial extraction for implant placement, also known as the socket shield technique. So this one's kind of cool. When you pull a tooth, particularly in the anterior, that bone is very, very thin. That buccal plate is very prone to break. And so, which makes it not ideal when you're going back with an implant. Your gingival crest gets real low, things like that. So a partial extraction procedure can be done. Now, here's some images of what that looks like, just so you can get it in your head. They're taking the crown or the coronal aspect off the tooth. Then they're using a specific burr set to remove kind of the lingual majority of the tooth. They're leaving a little thin buccal or facial shell of the root of the tooth there in the socket. And so there's some tooth is remaining behind. That's why it is a partial extraction. Okay. And so, and then usually a bone graft and an implant placement. So that's a D6104 and then a 6010 that's going in behind it. And so that's happening, and you're maintaining that extra little tooth there to help maintain and reinforce that bone, prevent that fracture from happening, and maintain that height of tissue on that arch, particularly in the anterior. So that is the socket shield technique. Again, D7252, great technique if you are placing anterior implants. I'd put that in your wheelhouse if you need to go take a course on that one. That's pretty cool. All right, next surgical code is nerve dissection. Now, more than likely, GPs are probably not going to be doing a lot of this. This is more in the realm of the oral surgeon. But once you're aware of the change, this is when you've got a nerve that you're worried about causing damage to due to the invasive nature of a particular extraction. So you're actually dissecting out that nerve from the surrounding tissues, and you're laying it aside so it doesn't get hurt or damaged while you're doing the extraction or whatever the other surgical procedure is that you're performing, and then you're putting everything back in place. So probably not one I'm going to be using in my office, that's for sure, but oral surgeons, absolutely, this may be something that's in their realm of possibility. Two new codes in orthodontics. Both of the codes that are new to orthodontics relate to orthognathic surgery. So you've got your regular comprehensive orthodontic treatment codes, but they felt like in these particular cases where there's a concomitant disease process, like you've got craniofacial syndromes. So maybe you've got Pierre-Robin syndrome, something like that, where it's, you're born with a facial defect and you've got to do a whole lot of surgery and a whole lot of different ortho to get this done. It's multi-phase and it's big, significant skeletal deformity. There's a way to document and report that this is a different treatment than just comprehensive ortho, which might be a clear aligner case. Okay. So big contrast between the two. So this specifies that, hey, this is a big one. Expect to see a whole lot more stuff coming. And so it flags that for the insurers as to what the situation is and carves that out as a separate type procedure. The periodic orthodontic treatment visit associated with that is also new. And so again, that is associated with orthognathic surgery. Again, probably not a GP type thing unless you're really, really into it. Nothing says you can't use. There are no codes that are specialist specific. Okay, let me make that clear. As long as it's within your knowledge base and within your ability to do that, within your licensing, then you can absolutely perform any of these procedures and report them using any CDT code. But this is a complex type procedure. So next and lastly, we've got two new codes that are at the tail end here. Administration of neuromodulators, that's BOTOX. Okay, we have a code this year for BOTOX and similar. And so these can be used either therapeutically or cosmetically. They actually submitted this to CMC as two separate codes. They had a cosmetic variant and they had a therapeutic variant for BOTOX. And they decided, well, nowhere else in the code set do we really break it out that way. So they combined it into one code. So it's for any type of use. Now, this is good and bad. Okay. It's great that we have a code in order to be able to document these things. And if your insurance plan says this is not a covered service, great. You can probably keep doing BOTOX like you always have. However, unfortunately, this also gives some payers the ability to add a fee schedule for BOTOX. And if that's the case, that's going to affect your ability to do BOTOX in certain situations. You're going to need to really make sure that your reimbursements are set if you are in network, in contract. If you're out of network, you can always balance bill a patient. That just means that's the maximum they're going to pay, but you can balance bill a patient for the difference. But if you are in network, you're limited to that fee schedule. It may affect your ability to deliver BOTOX to a patient. So same with this next one. The next one is dermal fillers. Okay. Dermal fillers is, things like Juvederm, things you're filling in these. Now that can be used cosmetically here, but there are some therapeutic uses for dermal fillers. You can plump up gingiva between, little areas, get rid of black triangles between teeth. And so that's, as I understand, that's nothing I've ever done. So that's not within my clinical wheelhouse, but that is something that evidently is done. And so it can be used both cosmetically and therapeutically. And they both fall under the same code, 9914. Again, potential for fee capping or for fee schedules if you are in network. So that's a concern. Last code we're going to touch on here. This is the unspecified sleep apnea services by report. Last year, we got a brand new category of service for sleep apnea. They carved out all the codes that were sleep apnea related, which were all 9,000 codes. They were all kind of mixed in with the adjunctive general services category service, but they've pulled those out and made their own category of service now for sleep apnea. But they didn't have an unspecified. All the other categories, the 12 that were existing, had an unspecified by report code. And sleep apnea has got a ton of things that really don't have a good dental code for. So this was very much needed. Now, note it is not a 99 code. It is not a 99 code. It's not even a 99 code. It is a 59 code just because 99.99 already existed. But they wanted to be able to get the closest code they could to numerically and work for the unspecified. So that's unspecified by report for sleep apnea. So with that, we're kind of wrapping up here. Here's a combination, just looking at how many changes there's been. This is just this year and last, okay? 2024 and 2025, 24 new codes in the last couple of years, 14 revised, 2 deleted, 1 whole new category of service. So that's a total of 40 changes plus a category of service just in the last 2 years. Make sure you're staying up to date on those resources. And now I mentioned this before. I want to give this to you guys. You can scan this now. It's a QR. That's going to lead you out to a download of all the code changes that happened for the last 3 years. So we're talking about 2025's code changes, this year's code changes, also last year's code changes, and the year before that. I want to make sure that you've got all these on your radar. Okay. And so this will be a quick reference guide. You'll be able to look back, make sure that you've got all those changes incorporated into your practice management system, that you understand how those codes are to be used. Now, it doesn't go into detail about how to use each code like the Dental Code and Confidence Manual does, but it does list out what the codes are and what their nomenclatures and descriptors are. So you can do your digging and do your research, make sure that you've that you've got that. So please scan that. And we also have, if you're feeling a little overwhelmed, there was a lot that I covered today. Absolutely reach out to your Henry Schein Field Services rep. Okay, they're going to be able to put you in contact with us, help you with the resources that we offer. And so certainly reach out to the business solutions team at Henry Schein. Their phone number is there, their email is there. And so please do initiate that conversation. They'll be happy to help you steer in the right direction. Make sure that you've got the support that you need to be able to code correctly, submit correctly, make sure you're getting these clean claims happen. So every single year we've got these changes. We've got to make sure that we're staying on top of them. So with that, we hit right at an hour, guys. And so I do have some Q&A that I'm going to go through. And so want to see how our, let's see, dental benefit companies handling language interpretation services. By definition, if you look at when I say ADA, that's the American Disabilities Act. Okay, there's specific language within that talks about the fact that we have to, as clinicians, provide interpretive services to our patients. Now, that could be language, that could be sign language also. And so there are resources that are out there to help you do that. We must legally provide those services, and we must do it at no charge to the patient. Because of such, there is a code, there is a way to report that, okay, but it's not something that we're really supposed to be tacking any fee on whatsoever. There are resources that are out there that allow you to do this. You don't have to hire an interpreter to come along with your patient. You really can do this on an iPad. There are services where you can call in or do it over the computer, and as you need to, and then it's by the minute. And so ADA has a good one that's pretty cheap. I can't remember the name of theirs. You can search ADA's website, but if you are an ADA member, it comes at a very low price per minute. And so you're able to get them on and do what you need to do, and then shut it off. And then if you need them again, you log back in and get them on again. So that's how we're handling those interpretations, our interpreter services for those types of things. We are some very special, wonderful, awesome managers. Yes, you are. Absolutely. You're special and you're awesome because you're here. You're taking the extra initiative to make sure that you are understanding these things. So, Marie, thank you for saying that. That's awesome. That's absolutely true. If 6081 is performed in conjunction with 4342 of some adjacent teeth, usually is not covered, is it considered part of the quadrant? Yes. The cleaning and scaling of implants falls under D1110, the prophylaxis. It falls under D4346. It falls under scaling and root planing as well. So if it's in a quadrant where you're already doing perio, you don't have to code that out with a 6081 separately. 6081 is a code that is just for when you're focusing on one specific implant and you're not really treating anything else. And so, or it may be several there side by side. But if you are doing perio in that quadrant, then implants are included in that definition now. So absolutely. 6081 code, can it be completed at the same time as 4341 or 4342? No, the 6081 specifically has language I think I showed you at the very bottom of its descriptor that says not to be performed in conjunction. So meaning it can be done, it just has to be done on a different date of service. And that's unfortunate. I kind of wish they would change it to be able to be done on the same date of service, but it would really fall under the 4341 or 4342 if you're doing it same day. It really is not something that's to be done separately. So, okay. A clarification was suggested to strike inflammation because mucositis is inflammation. Increased probing depths is not the definition of mucositis. It's the parameter for perioimplantitis. This year, we submitted a code action request to support periimplantitis. So thank you, Siobhan, for that clarity. Absolutely. And so we're looking, this last year, like I said, the change was because it did say inflammation or mucositis. They really took inflammation off and made it specifically about mucositis. And so that was the parameter for it being periimplantitis and needing its own individual codes. That was from Dental Codology Consortium, which is I'm good friends with several folks. Kathy Forbes is a good friend of mine, and so they submitted D6180 as well. So looking on down, is this recorded and can we access this later? I believe. Now I'll throw to Shirley on that answer. Is this recorded? Is it going to be available?
Yes,
It
it
is.
is. It is
Absolutely.
being
Okay.
recorded.
I thought so.
Yep, and we're going to be sending out a link to the live recording sometime over the next week.
Okay. Someone was asking for the QR code again. It is here. And so I wanted to put that back up. Let's see. Codes for laser codes. Oh, that's a good one. I've got a whole podcast on when you can use laser cutting procedures and for things like bacterial reduction and also for oh gosh, what is it? LANAP and LAPIP. Gosh, took me a minute to get that out of my head. It's laser assisted new attachment procedure and laser assisted implant procedures. And so ADA has been very specific that laser to them is considered a tool. And so coding for laser specifically is not something we're probably going to see. About every year, they've submitted codes for lasers, but laser is a tool like scalpel, electrosurge, these other things. And so they don't consider that. The coding is for specific procedures. And so as such, they consider that a tool in the delivery of those codes. For instance, the AAP, or the Association for Periodontics, has come out and said when you're talking about the LANAP procedure, LANAP specifically is a very conservative procedure that is done through the sulcus around the tooth. There is no flap that's laid. Okay. And so there is bone that is changed. Okay. And that meets the definition, but it can't even be coded out using the gingival or osseous surgery codes in the periodontal department because there is no full thickness flap laid. And so the way they say to code that is actually to use 8999 unspecified and then to ask for the alternate benefit of the osseous surgery codes. And so now, can you submit using unspecified codes? There's a 4999, there's even a 2999 that could be appropriate for things like laser bacterial reduction, LBR, and things like that. It's a little gray, okay? But if you're doing it for a reason or a purpose that is not included in the actual procedure that you are delivering, for instance, a normal prophy, you're not sterilizing pockets in a prophy, okay? So the laser in that usage or in a 4910 or laser assisted periodontal therapy, those things could be coded out using that 999. Now, the vast majority of plans are going to tell you that laser cannot be coded or submitted separately as a procedure. They're going to consider that inclusive to the procedure that is being delivered and that it should not be coded as a separate thing. And so because of that, you absolutely can document it. You have every right to submit it if you feel like it is a separate procedure, okay, not the same procedure. And so you're able to put it on there, but the code or the plan document language is going to say that they consider that all a part of the same thing. They're not going to reimburse it. Most of them are going to tell you that you are not able to charge the patient separately. Fee for service, different story. You guys don't have the handcuffs. You're able to kind of do some things that you can't without. If you're in contract, you're talking about breaking some contractual obligations if that's the case. And so, let's see, insurance paid a different crown code than 7040. If insurance paid under a different crown code than D70 2740, could the provider charge a different the patient a different cost? I want to make sure that I've got this understanding. Don't ever, because I saw this the other day. I saw somebody charging out gold crowns by they're submitting 2740 instead of the gold crown code, and then they were charging a materials upgrade cost. That's hugely not a no-no. Do not do things like that. Code for what you do. If you're doing a porcelain crown, that also includes zirconia. Code that out as a all porcelain restoration. Make sure that you're not calling it something else. Okay. If you're doing a gold crown, you got to call it a gold crown. And most of the time, the insurance, if you look at their plan documents, they're going to consider all materials, materials costs and laboratory costs as a part of that procedure. Now that makes it where if you're in network, a lot of times certain procedures are not paying you enough to really be able to do that procedure or offer that through your office. So uh, there are some kind of workarounds to it, including optional services, things like that. I like the pathways that actually let the insurer know what you're doing and getting their permission to do things. I don't like waivers, not a fan. And so there's some big legal issues and things that kind of come back to bite you when you're talking about trying to do these insurance waivers. That's a whole article and story unto itself. For instance, there's the HIPAA waiver, the high-tech waiver that is legal, but it comes at great cost. Those are, you're messing with federal law, first off. And so those are do not submit to insurance laws. Those were originally created by, it was for the purposes of not submitting HIV testing to an employer, letting them know that you were getting tested for HIV. This came back from the 80s. Some dentists have picked up on this and said, well, this is a way to get out of submitting things to insurance. Okay, well, maybe, but there's so many things that have to be done. You have to keep all those services completely separated. You can never let the insurer know about those particular services. So what happens the very first time you take a radiograph and there's an implant there that wasn't there before, or there's a tooth missing that wasn't there before? When that happens, you've had a HIPAA breach. Okay. Even on audit, you're not able to do that. One of the worst things is they can rescind that at any time. I've seen a lot of patients who have gotten savvy. And the doctor's done it all on 4Ks, all these implants, all this restoration, $70,000 worth of work. The patient rescinds the HIPAA form, the high-tech waiver, says, I don't want the protection anymore. I want this turned into insurance. Insurance then subsequently makes the doctor write off the entire case. I've seen it be a big issue in audits. I've seen it be a big issue. And you're messing with federal law. Okay. And so that opens up a whole new heap of potential consequences that you would not have if it was just a contractual issue. You can get kicked out of a contract, but I don't want to mess with anything federal. Okay. So, how can attendees attend the ADA CMC meeting in person or virtual? If you're interested in those kind of things, there is a link on ADA's website. If you go to ADA and you search for the Code Maintenance Committee, you will find a link there, both with the form that you can fill out if you want to do a submission for a proposed ADA code. And you kind of have, there's some certain criteria that have to be met. It has to be unique and specific. It has to not be something that is proprietary, like, only my company creates this product. They're not going to create a code for that. So there's certain criteria that must be met. Those have to be in before November the 1st, and then it will get discussed at the following March CMC meeting. That is open for virtual and in-person participation. There is a link there as well to that. You can put in your submission and give them your information, and you can participate with that meeting. So, guys, we're already well past our cutoff time. And so I know there were a few questions I didn't quite get to. I would love to be able to touch on some of those others if I can. I'm going to get this, what these questions were, and maybe be able to answer these directly to you in email. You can certainly reach out to me. My contact information, if you go to dentalcoding.com, dentalcoding.com is Practice Booster's website. That'll also show you our online services and our code advisor. Everything I've said today is pretty much in our books. Okay, the Dental Coding with Confidence manual and the online code advisor. We also break a lot of it out on the Insurance Solutions newsletter that comes out. and our consulting services are there as well. I'd love for you to come check us out there, dentalcoding.com. Otherwise, that kind of wraps us up for tonight. And so I thank you so much for your attention and your participation. Thanks for going above and beyond and sitting here listening to me on a Thursday night. You could be with your family and you're listening to me rattle about CDT codes. So thanks for going the extra mile. And with that, I'm turning it back over to, well, Shirley, it says your name's Henry, but I know better. So, all
Right.
right, throwing it
Thank
back to
you
you.
so much. No, thank you so much. That was wonderful. And Dr. Grobmyer, I also added your website to our chat for everyone. So you'll see there dentalcoding.com as well. You guys can go ahead and copy and paste that. But with that, I want to thank you so much, Dr. Grobmyer. That was just wonderful. And thank you for a wonderful presentation. And thank you all for joining
Absolutely.
us tonight. Yeah, we
So
did
happy to
record
be able to
again.
do it.
Yes, thank you. Lots of great information. We did record this evening's webinar. And as I said before, we're going to be emailing the recording out sometime in the next week. So we'd appreciate your feedback. That's going to be via our survey. It's going to pop up on your screens shortly. But again, I want to thank you all for joining us, and we look forward to seeing you on future webinars. And yes, make sure you reach out to Dr. Grobmyer with any extra questions. Have a great night.
Thank you all.
Thank you. Bye-bye.